Well, hello everyone, and welcome to the 2026 Engagement Lounge webinar series presented by the Association of Neurovascular Clinicians. My name is Kara Guthrie Chu, and I will be moderating this session entitled Stroke Navigator, Gaining Administrative Buy-in. ANVC is dedicated to the creation of seamless neurovascular care services led by evidence-empowered clinicians that fully support the holistic needs of patients and their families, because stroke patients deserve nothing less. For more information about ANVC, please go to the www.anvc.org website and become a member. We do have a few housekeeping items before we begin today. Number one, this session will be recorded and made available in the members only section of our ANVC website. However, only viewers who attend this live session in its entirety will receive one continuing education hour. Viewers will receive an evaluation from Arizona State University. After completing and submitting the evaluation, participating viewers will receive a continuing education certificate. But again, you must attend the entire live session to be eligible to receive credit. If you are joining the webinar today under a phone number or nickname, please enter your name in the chat or send an email to info@anvc.org in order to ensure you receive the evaluation for CE credit. Please feel free to enter any comments or questions into the chat throughout this presentation, and at the very end, we will review questions with our guest speaker. Now, I am proud to introduce our guest speaker for this webinar, Patty Noah. Patty Noah is the Director of AHN Stroke Programs, Manager of Allegheny General Hospital Comprehensive Stroke Program. She is an adjunct faculty student at Misericordia University. Patty received her bachelor in nursing from Wheeling Jesuit University in Wheeling, West Virginia, and went on to receive her master in nursing education from Duquesne University, Pittsburgh, Pennsylvania. Excuse me. She has served in various nursing and IT roles at Allegheny General Hospital, ranging from staff nurse, nursing director of the neuro ICU, staff development director, and including her current role in the Neuroscience Institute Allegheny Health Network. She leads collaboration among the stroke programs throughout the Neuroscience Institute and Allegheny Health Network. She is a member of ANVC and sits on the ANVC Education Committee. Patty has also published numerous academic articles in her field. So without further ado, welcome, Patty. We look forward to your wonderful presentation.
Thank you very much. Let me share and start the presentation. Okay. As Carrie said, my name is Patty Noah. We're going to talk a little bit about Stroke Navigator, the program itself. How do you develop a program, and how do you gain the buy-in of your administration? I have no disclosures at this time. A little bit of background about us. Allegheny Health Network. We're a network that consists of Urban Comprehensive Stroke Center. We have 9 primary stroke centers, as well as 4 micro hospitals that triage and transfer acute stroke patients to both our PSC and our CSCs as appropriate. In addition, we are a telestroke hub servicing both our in-network hospitals, our micro hospitals, as well as 10 additional out-of-network facilities. We also have 4 in-network IPRs. As a network, we treat roughly 4,000 stroke patients annually, which come from us from a very large service area, which include 29 counties in Pennsylvania and a portion of New York, Ohio, and West Virginia. We sit on a little bit of the tri-state area, as we call it. We're fortunate to be part of an integrated delivery network, partnering with Highmark Health the integrated delivery network provides patients with care through several centers of excellence and many advanced specialties. As a model, it drives innovation and efficiencies that result in exceptional, more affordable health care for patients. Thanks to the support of the integrated delivery network, we were able to implement a stroke nurse navigator program at Allegheny Health Network in 2018 with several goals in mind. These included improving care transitions. Oh, I was just got a text saying we can't see the slides. So thank you for that. And let me see. Let me end show and let me try this again. Sorry about that. It worked. Is that better?
I don't see it yet, Patty.
Okay. Now it worked for us when we did it ourselves, right?
Yeah.
All right, so let's share screen. And let's share screen. Let's share screen 1 and see if that works. Oh my.
Okay. That is showing a screen. It's just not your.
I was going to say that is showing my computer.
Yeah.
Okay. Well, now that I've totally closed my presentation. Well, we thought we had it working.
Mm.
All right, let's try this again.
It- there you go, Patty.
Now you
Perfect.
see it?
You got
Okay.
it.
All
That's it.
right. All right, so let's start screen. Let's start the slideshow. All right, we can still see it?
Yes, perfect.
Perfect. Okay, back to the no disclosures. Back to who we are and what we are. So, I'll continue. I think I remember where I was, that we are fortunate to be part of an integrated healthcare delivery system. We partner with Highmark Health. And again, the integrated delivery network provides patients with care through several centers of excellence and many advanced specialties. And as a model, it drives innovation and efficiencies that result in exceptional, more affordable care for our patients. And thanks to the support of this integrated model, this is how we were able to implement our Stroke Nurse Navigator program in November. This included what we wanted to do with the Stroke Nurse Navigator was improve our care transitions into the community, including discharges not only to home, but to local facilities. We wanted to reduce our unplanned care, our readmissions, and improving just the overall quality of care and our patient experience throughout the system. So, what were some of the issues that we looked at? First, when we talked to patients and families, they really reported information overload. They were being discharged with tons and tons of unclear instructions. They didn't understand their discharge plan. They didn't understand all the new medications. They were unsure where do they go next? Who do they need to see after they left the hospital? And worse, the health system's so complex that they had just the difficulty in navigating the healthcare system itself. When we looked at IPRs and SNFs, which unfortunately, some of our patients do go to these entities, they were delivering inadequate care. And not due to the knowledge deficit among the interdisciplinary care, but um, they didn't have the right tools, the proper tools and education to provide the best care for the stroke patient. And there was also a significant lack of communication between the primary care providers, the home care staff, the outpatient therapist, the specialist, and the neurology team regarding what is this patient's true plan of care. So we all sat down at a table for a few months, actually, probably quite a few months. That's why we didn't implement till November, and talked about what we're going to do, how are we going to do this, what are we going to do. So based on all the identified opportunities for improvement, we implemented this program. Initially, it was funded through the integrated delivery system. That's really important to remember throughout this, is that we were funded not by our hospital, but by the integrated health system. The Navigator program was established to bridge the gap between the acute hospitalization and the post-acute care, in addition to assist the patients to navigate our complex healthcare systems. Since the inception of our Navigator program, we have enrolled over 10,000 acute ischemic stroke patients and around 1,000 hemorrhagic patients into our program. We didn't start enrolling our hemorrhagic patients until 2020. We enrolled these patients and we initially followed them for 90 days post their episode of care. But as our program has evolved, we now follow them for a year post-discharge by a dedicated navigator. So once you meet your navigator, that is your navigator throughout your entire episode of care, which we defined as a year now. In May of 2024, our team did publish an article in Stroke Clinician regarding the role development of a stroke nurse navigator based on our experience. So if you want to learn more, that article tells you all that we did and how we did do it. So what really is navigation, right? By definition, it's a patient-centered healthcare delivery model aimed at improving outcomes and easing the burden of the complex healthcare system for patients and their caregivers. Navigation of the stroke patient is new and an emerging field. We all know that navigation has been around a long time in the cancer world. So as a result, there really is very little information in the literature regarding the role, its responsibilities, the outcomes, and the financial benefits of hiring stroke nurse navigators. And as we all know, unfortunately, we are a business, so we always have to think about the financial benefits that we are going to yield. Not unlike stroke, most complex disease states require a large commitment by patients. And unfortunately for our patients, usually their families. And non-compliance to treatment regimens are not uncommon because of these complications and or lack of support that our patients may have. When a nurse is navigating the care, it can improve the compliance and therefore improves the outcome and the overall health of the patient. As medicine becomes more specialized, patients and caregivers need a healthcare expert to guide them through the complexities of care, from diagnosis to survivorship. Hence why we start our program on admission to the hospital and again 1 year post-discharge. The role of the nurse navigator can provide this expertise from a proven return on investment for forward-thinking organizations that put the patient at the center of their care model. Again, another real important thing to remember as we talk throughout the rest of this conversation. So what is the navigator role, right? What do they really do? The job of the navigator begins, like I said, in the anchor stay of the hospital. The navigator meets the patient and family and serves as a liaison during the hospital stay and to assist with discharge planning. They provide stroke education to the patients and family during the hospital stay. This education is above and beyond what the bedside nurse provides. And I think that's real important to remember. And I may say that again a little bit later on. We schedule appointments and testing that the patient doesn't, so the patient doesn't have to do that once they're discharged. We schedule it for them prior to them being discharged. Once the patient is discharged, the navigator then follows up with the patient. She works to improve that transition. Remember, that was one of the goals I said we wanted to do when we developed the program. Regardless of discharge disposition, we follow all of our patients. We follow them a little bit differently, though. For the patients who are discharged home, we contact that patient by phone and review the discharge instructions, medications, follow-ups, and provide education on secondary stroke education and stroke prevention. Um, we require, well, should I say I require that the nurse navigators reach out to those patients that are being discharged home within 48 business hours of discharge. So that gives us a little leeway for a Friday, Saturday, or like upcoming weekend with a holiday on Monday. That is their goal, to reach out to these patients and review the above with them. We also contact, if the patient goes to inpatient rehab or SNF, we'll contact those facilities. The navigators will introduce themselves, tell them who they are. They will make sure that the facility has and understands the after visit summary, the plan of care for that patient, when there's a follow-up, where that follow-up appointment is scheduled. Once these patients are then discharged home from that facility, that is when the navigator will start reaching out to that patient. Again, at that point, we're providing to the patient the secondary prevention. We assist in any of the needs that they may have now that they have gone home. We also work with family members. We provide emotional support for them, referral to support groups, caregiver education, as well as stroke prevention education. To remember, stroke is just not patient. It really does encounter the entire family, and changes need to be made for that family. You'll notice that the last thing on this list is relationship development. It has been really absolutely very cool to see some of the relationships that has been built between the navigators and their patients. This to me is the most important part of this role. With so many of our patients and their families, and again, not just the relationship between the patient and the navigator, but the family and the navigators. Their close relationship and their bond has been really priceless. The patients and their loved ones look to us as the experts in our field. They trust what we tell them. They trust the opinions we give. They are truly grateful to have the navigators and the program in their lives. They listen to our education. They're excited to tell us not only what's not working for them or the problems they may be having, but they're always so happy to share what successes they have also experienced. So it's a win-win for everybody in the role. So the navigator also are active members in the inpatient stroke team. I think this is really, really important that the navigators that are coming on board, and as you build your program, is that that the navigator role is not an office job. It really is, the role really has to span the inpatient and outpatient worlds. How can you ensure that a patient or family member understands their diagnosis, plan of care, their follow-up requirements, and their necessary lifestyle changes, right, to prevent future strokes? If you yourself don't know all the details, if you're sitting in an office and you're not out there, you don't know what the doctors are saying, you don't know what the therapists are saying. You can read the notes, right? We can all read progress notes, but we all know that sometimes things are missing in the medical record that are really vital to the patient plan. So the navigator works closely with the physicians, case managers, social workers, nursing staff to make sure that nothing is overlooked. This means attending physician rounds, discharge planning rounds, talking with the patient and family and other members of the care team to identify these needs, and acting as those needs are and supporting the needs while the patient is in-house. For example, as I said earlier, we get a lot of patients from multiple states, many different counties surrounding Pittsburgh. The patient might need a PCP. So they don't know where to go. They don't know, how to start this process. So the navigator can help. They find them a PCP. They arrange for a visit prior to their hospital discharge. Maybe the patient has food insecurity. So the navigator can assist the social worker in getting easily accessible, healthy food choices for the patient. It can also mean helping to advocate for the best discharge plan for the patient. Maybe it's documented that they're not rehab eligible. advocate for them, work with the patient, encourage the patient a little bit more, work with the rehab team in order to get that patient into rehab. Again, what's best for the patient. Again, additionally, being with the inpatient team also allows the navigator to meet the patient very early and develop that relationship with them while they're in the hospital, that you're not getting some random phone call once they're discharged from totally at that point a stranger, right? When they see your number come up, they know it's you, they want to answer the phone. Proper follow-up care is necessary to improve patient outcomes. Because navigators are uniquely positioned between both the inpatient and outpatient worlds. And as I said earlier, it's a dedicated navigator. So once you see that patient, know that patient, you have that patient for the entire episode. They have the opportunity to schedule appointments for the patients prior to discharge. And as part of being the neurology neurosurgery team, the navigators at a minimum have access to all of these schedules in order to make these appointments work. In some instances, again, like I said, they schedule a PCP, maybe a specialist appointment that might need made. Maybe they need a follow-up CT scan or carotid imaging before they come back to see the physician. The navigator can work and schedule those maybe all on the same day. Start in the morning, see the physician in the afternoon to make it more convenient for the patient and the family to get here. We now see patients in multiple different areas. Therefore, we're able to, look at the patient's address, talk to the patient, provide them other accessible areas that we're located to make it more convenient for them. A lot of our patients are, of course, elderly, and some of them just don't want to drive back to the city. So we get them into our outer offices to make it more convenient. The navigators also must be able to educate the patient. Again, this also includes the family, right? And the staff sometimes. Staffer comes, staff goes. You have, a traveler here or there. It's one of the many reasons that the navigators must be a stroke expert. And I underline all caps, bold, must be a stroke expert. Education provided to the patient and family should never, never again, I'll repeat that, never, never again replace the education that the bedside nurse does. What we do is up and beyond that basic care. And I'm going to say basic education because it is basic education that they get from the bedside nurses. We're going to specialize more into that care. We should, again, education begins during that anchor hospitalization and continues throughout the entire episode. They're responsible for providing individualized education, guidance regarding therapeutic lifestyle changes, risk factors such as diet, exercise, smoking cessation. They also provide disease-specific teaching and medication teaching, again with our goals of solidifying, understanding, and improving compliance, effectively influencing the lifestyle changes, reducing the risk of recurrent stroke. Education should be provided via multiple modalities, right? Adult educators learn in many different ways. We all don't learn the same way. Some of these include verbal instructions, over the phone, in person, written instructions. We send a lot of things out monthly. We do, the little monthly, I call it a newsletter, and I'm sure Leslie and the girls have something else that they call it, but it might be blueberry month. So we send them healthy things about blueberries, maybe some, recipes at that time. So every month there's something going out, plus again, their education. The navigators have the benefit of being part of the inpatient team, so they have had the opportunity to help in educating staff in real time, as well as identifying potential knowledge deficits and gaps. As an integral part of the team, stroke nurse navigators work very closely with primary care providers and other specialists to improve the fragmented care. Think about some of the care that happens. Think about maybe some of your own care. It doesn't have to be stroke related. And you try to piece it all together. Now add that on as being a patient that's had a stroke and they're trying to piece A, B, and C together to get D. The services that they include social work engagement, community resource access, psychosocial referrals, referrals for post-stroke complications such as spasticity, cognitive decline, maybe post-stroke depression and fatigue. What do they do? Where do they go? Is this normal? The stroke nurse navigator should also be responsible for post-discharge follow-up phone calls for the patients discharged home. Calls are critical in identifying potential errors, clarifying any of their medication or their plan of care. Again, follow up for their appointments. We also have additional touch points throughout our episode of care. Again, I said we used to follow our patients for 90 days. We now follow each patient for a year. Our nurse navigators also help the family in family medical leaves. Sometimes it's just a medical leave for the patient. Anything that can ease the burden of the patient and the family fits into this nurse navigator function list. Um, Again, I said earlier that those patients that are discharged to a facility, our old way, I'm not going to go into, we learned that you really can't engage with the facilities like we wanted to. It just didn't work. So we reach out, we tell them who we are, what we do, and here we are. If you have questions, let us know, let us help you. This we have seen to decrease some emergency room visits from SNFs or IPRs. It helps us in that sense. Once again, we follow up with them once they leave the hospital. Oh, I'm sorry, or the SNF or the IPR, right? Um, Throughout our multiple calls that we also do modified rankings, to see how their improvements have gone. Where are they at? We add this into the data that we collect also. Um, Again, to pretty much sum up their functions, there's minimal literature that really shows the potential successes and benefits of a Navigator program. So as innovators, we are trying to share our program, share the successes that we've had, also share the failures. So people don't have to go through the failures; they can skip what we failed on and share our lessons learned. So we can help prove the necessity and really the benefit of this role for our patients and our families. So how do you build a program? Touch very briefly on this. Again, and I'll refer you back to that article, which really goes into detail on the program development. Again, developed it with several goals in mind. We included improving the care transition to the community, discharge to home, to local facilities. Really, our main goal is to reduce unplanned care and readmissions, so costly, right? Improving the overall quality of care and the patient experience. One day you're fine, and the next day you're laying in the hospital with a stroke, and your life is totally changed forever. How do we make that experience a good experience? And not just for the patient, but also for the family. The development team did not provide the navigators with a defined process when we did this, when we started this. I'll never forget our physician who was key, who's now no longer with us, but was very key in developing this. The very first nurse navigator we interviewed, she's like, well, can you explain what a day in the life of a nurse navigator would look like? And he looked at her and said, I can today, but I guarantee you in a month, it won't be the same. And he was so right, because it's just always a evolving job. This worked. This didn't work. How can we fix it? How can let's just get rid of it and try something different. That's really the way the program has been developed. And I think that's what has made us so successful. Um, the we really allowed, my administration, we allowed the navigators to utilize their expertise. Again, why I said somebody with stroke knowledge is key and essential to this role. Their critical thinking skills to define their role, what the daily operations were going to be, to create the tools within the EMR. We've built many tools in our EMR. We've, been very lucky that we've had the assistance of our IT team to help us to build these tools to assist with our program management and our evaluation. The early program we focus on were patients with a primary diagnosis of acute stroke. We got that process down. We aim to reduce those readmissions, and we'll talk about those in a little bit. We wanted to optimize the care that they received. We wanted to look at the integrated delivery system. And as I said earlier, we looked at some local SNFs and IPRs that weren't hours, and we tried to work with them. Again, that didn't really work for multiple different reasons. As their turnover their turnover was really very high. The facilities were busy. You always couldn't get someone to sit and talk with you. So, I mean, we did go out and provide tons and tons of education to multiple facilities. And as I said earlier, it's not because the SNFs and the IPRs weren't educated. They just didn't have the right tools and what they should be looking at. How should they be caring for the stroke patient? So we've done that. Again, sometimes very difficult to keep up with that education there. So that's why we've changed our model that I talked about, that we follow them closer. We follow on a periphery when they're inpatient, follow them closer once they're discharged from that facility. Then, okay, let's see, where are we at? The role evolution, again, I said we focused on the community discharges. We increased our touch points. Increasing our touch points really led to us being able to prevent readmissions, prevent the trip back to the ED, able to increase our secondary prevention education. We have frequent adjustments. We're always looking to see what can we change, what can we do better, what can we get rid of. Every I would say September, October, we sit down, we start to plan our next year. We look at our data, we look at our successes for that previous year. What was working, what wasn't working. We talk about what is value, what is added value versus what do we do just because we said we wanted to do it and we checked the box to say it was done. That's unnecessary work, unnecessary task. So let's get rid of those. We then looked at, we now not only do we follow our hemorrhagic and our ischemic strokes, but we have now added our high-risk TIAs onto our complement of patients that we cover. So we're actually covering the whole gamma of stroke definition for our patients. So we already talked about the specific job responsibility. So now let's talk about what kind of person can take on this unique role. I've said it a couple times already, but I'll say it again. A stroke nurse navigator needs to be an evidence-based person that is an expert in all things stroke. This includes all of the evidence-based practice, the current guidelines, the regulatory standards. What are the policies and procedures of your particular hospital? What, as well as primary and secondary prevention. It's nearly impossible to properly do this job without knowing all of this. You're probably sitting there thinking, all right, that sort of sounds like a little bit of the coordinator role for those of you that are coordinators. You need to know the regulatory standards, the guidelines. That's right. But the importance of being able to work collaboratively, literally work as a team, and get to the point where you, as the coordinator, and your navigator are thinking the same thing, talking the same thing. When you're talking about your patient, you're seeing that patient. So you're really a team, but you're one in one, right? The stroke coordinator needs to focus on that regulatory stuff and the management, while the navigator is focusing on the patient. But all in all, your ultimate goal is the same: success for the patient, success for your program. And I will stress, it's so very important that your administration understands the differences in the role, so they don't see you as one, right? But how the two of you complement each other in establishing and maintaining that successful program that's patient-centered, that you prove increased patient outcomes for the patient and for your institution. In addition to being a stroke expert, the navigator must have a high level of organization and be able to be creative and flexible. Again, I said earlier, Dr. Tao said, what you do today is not going to be what you do tomorrow or the next month. So true. No 2 days are the same. It really depends on the patient. It depends on the conversations that you're having. You have to be able to bend and adapt to individual needs, like is very vital and on a dime. Um, they have to be strong interpersonal skills. They must be able to interact with the medical staff. The medical staff also needs to have confidence in them and know that they know what they're doing, what they're talking about when they're talking to the patient and the family. They need to be able to communicate with community members to get these patients integrated back into the community. That's our goal, is to get our patients back into the community. Navigator also must be very well versed in data collection and analysis. I just don't want someone to put data on a spreadsheet and say, here you go. You need to look at your data. It's your data. It's your patient data. What's it telling you? What can you do different? What can we do differently? Then look at it as a team and as a system. Um, and again, I've said it multiple times already, but so very important to the success of the program. Why? Because without data, your program will have no way to show its value and return on investment, and will likely not be supported by your administration. It took me a while to accept the thought process that this is a business, because I'm a nurse and I want my patient to have a good outcome, but it's a business and we have to be successful and support the administration. And to buy the support of the administration, we need to show how we're going to bring in that return on investment, and not always looking at the direct dollar and cent signs. So, robust data collection, ongoing improvement, adjustment, innovations. Start small and build as you learn. Don't go out and try to implement Allegheny General's program today. Start small, work out all of your bugs that you might have at your institution and grow to be bigger. You'll be more successful in doing that. Now, what we came for, return on investment, and how do we get and show this um, to our administration? How do you show, once you review the episode of care, you can only decrease the cost of the inpatient care so much, right? You can only eliminate so many unnecessary tests. You can, maybe not do daily blood work. You can eliminate that a little bit to decrease some of that cost of the episode. That can only get you so far. So this is the task we took on, but again, without the multiple data points that we collect and are constantly adding and subtracting every October, November, we're adding, we're subtracting, and we may see something midpoint. This would be something really good. Okay, what do we think? Decisions are never made by me. They're made by our team. And I think that's what makes us so successful too. We sit down, we discuss it, we add it, we subtract it. And depending on what we deem valuable to the program. So what were some of the things we did? We looked at follow-up care. When we started the program, we looked at what was the follow-up care in the clinic? What happened to the patients when they were discharged? Did they come back? Did they not come back? While scheduling the appointment is important, first step, it's irrelevant if the patient doesn't attend the appointment, right? So what you can see on the graphs is pre and post Navigator program. As you can see, patients were more likely to attend the stroke clinic appointment post Navigator than pre Navigator. And this result is statistically important. So pre Navigator, we had about 49.6% of the patients that attended their appointment. We also had about 42.5% that never did schedule an appointment or a follow-up. So they were lost to the system, they were lost to the clinic. Our percentage of patients, of people who never scheduled the appointment has decreased significantly. Look at that, from 42.5 to 9.4. And a lot of these that did not schedule were what we consider those that went to a SNF, those that went to an LTAC, that would have had no benefit in coming back to the clinic. And some were just those that just didn't show up also, or just, no, those were no shows, sorry. that we just felt would not benefit from getting back into the clinic. Our percentage of people, we evaluated the factors that could influence the scheduling. We found that patients, look here, not 67.3% post Navigator role followed up in the clinic. So these patients now got their appointment prior to being discharged. If they were discharged on a Friday afternoon or Saturday or Sunday, our residents would secure chat the navigator, the patient's navigator, because they're listed in the chart as one of their caregivers, and say, hey, Mrs. Jones left on Friday, need to see in 3 weeks. That navigator would reach out on Monday to Mrs. Jones and say, hey, I can get you an appointment this day, this time at this clinic, and give it to them there. So yes, they were discharged without their appointment, but they were called and given their appointment within those 48 hours. What we found out, our patients were 9 times more likely to come to the appointment if it was scheduled before they were discharged. We also work with other offices and testing departments, again, like I said earlier, to try to coordinate all of their visits into one day so it's more convenient for the patient. So patients are more likely to attend the clinic and follow up if they're scheduled prior to discharge. Also, patients are more likely to schedule appointments since the initiation of the Navigator program. And again, in summary, that we found all of this. Therefore, increase in follow-up appointments with our clinic was a data point that proved a return on investment. Who thought that this is really a return on investment? Well, if you think about 67% not coming back to your clinic, and then you have your increase coming back to the clinic, that's money that you weren't making. So there is a return on investment there that doesn't fall into that episode of care. So again, not always looked at as that, but with the proof was within the spreadsheet. So again, importance of great data collection. And this is how we kept our data. We followed the patients that came and showed up at the clinic. Again, just another way to look at our high engagement and our clinic follow-up. The patients, who, and we defined high engagement as those patients that followed up with their navigator at least 4 to 5 times, versus anybody who was less than 4 times are considered a low engagement in following and contacting with their navigator post discharge. And as you can see, that we had 64, almost 65% of the patients who engaged with their navigator did follow up with the clinic versus those who did not. You can't make a patient answer the phone, right? I think that's probably some of the frustrations that we had and still have, is trying to get a hold of a patient at different times, throughout different times. But we're always here when and if they ever need us. I think just not long ago, we had a patient who had never answered a navigator phone call. And I mean, never answered a navigator phone call. And this person was a medical professional also. And we ran into this person, and we were actually at a similar engagement, and complimented highly how great the navigator was. He literally spoke to the navigator like 3 weeks prior to us seeing him. So it was just very frustrating. And I still think that falls to be one of our biggest frustrations. But we're always there for them. If they call, we answer, we do what we can for them. The other thing we looked at are readmissions, right? So the navigators look at 90-day readmissions, and they look at all readmissions. So these readmissions would include more than what maybe the CMS or U.S. News and World Report would look at. They look at even we look in CarePort is a system that we use that you can see that patients like journey, I guess I'm using Kelly's word there. And in that journey, you can see where a patient's been hospitalized, but we're not always able to see what their chief complaint was, or what the DRG was for that patient. So we're not sure if it's planned or not. So we're probably overestimating when we look at these. But it still showed that those patients that didn't engage often with their navigator had a higher 90-day readmission rate than those that did engage more with their navigator. So again, another real important role in the navigator and the attempts that are made. We utilize the role. I'm kind of a baseball guru and I love it. We utilize the rules three strikes, you're out, because you know you had to have a definition of how often do you try. You can't try forever for a 7-day call or a 90-day call. So you get 3 attempts to reach that goal. Does that mean if they don't answer you in 3 times at 7 days, do you not try at your 15-day call? No, you try again and get 3 strikes, you're out at your 15-day call. So at each touch point, we utilize 3 strikes and you're out, is what we do. But again, as I go back and say that the more engagement that they have with their navigator, the decrease in the 90-day readmission rate that the patient has shown in our patient population anyways. So in summary, for our engagement, they're less likely to have an unplanned readmission. Patients are more likely to schedule their appointments, attend the appointments if they engage more with their navigator, and their 90-day outcomes were better in patients who were highly engaged with their navigator. And again, like I said, we do modified Rankins at admission, discharge, 90 days, 6 months, in a year. So we have those different, we can look at the different outcomes as the patient goes through their episodic care. So what I wanted to do to also show or hope to show a return on investment for our patients is I do the 30-day all-cause readmissions for CMS for the hospital. So when you look at data and you look at what's published out there, historically, the rates often cited is between 12 and 15% in the United States for, though some studies might show it a little bit higher, some showed a little bit lower, depending on the specific types of strokes. What I was able to find out there was that approximately like 12.4% of ischemic strokes have a 30-day readmission, which, the ischemic strokes, as we all know, is 80% of the entire stroke population. Our ICHs have approximately 13.7% of readmission, and our subarachnoids about 11.5%. The literature says that more than 90% of those readmissions are unplanned, and up to 13% are considered potentially avoidable or preventable readmissions. So there are several factors that do affect or influence the likelihood of patients returning to the hospital within those 30 days. Age and comorbidities, right? Older patients that have a higher burden of pre-existing conditions, diabetes, hypertension, heart disease, that's where the navigator comes into play. They do further education on diabetes. They do further hypertension, cardiac education with these patients that are individualized and specific for that patient. In order to prevent them from having that readmission related to their pre-existing conditions. And we also face a challenge in Allegheny County is that depending on the time of the year, we're either first or second in the oldest population as compared to Dade County, Florida. So we have that very elderly population. Also, the treatment availability. I found that patients who receive specialized recannulation or EVT, they have a lower risk of readmissions. And I look back, we do approximately 250 endovascular therapies a year at our system. And what I really was like thrilled to see, and this is where I see the Navigator program showing the biggest bang for its money is our discharge quality. The robust post-acute care program, our Navigator program that enhances the structured transition of care, the transition of plan, getting them out back into the community, significantly reduces readmissions, and access to follow-up care. And like I said earlier, we now have that access. We kind of say we have Northeast, West, and South offices. Where do you live? Where are we getting you into that access at? So they have that availability. So our all-cause readmission rate has been lower even when we started pre-Navigator. All our 30-day all-cause readmission was at 5%. Um, the first year we were implemented, we dropped to 4%. Since then, we have been at 3%. Can't get lower than 3%. But what I was talking to Leslie, one of my navigators, about today was when I was doing this presentation, I went back and was looking at our readmissions again. And what I found, which now has me thinking, now I have another research to do, is January, July, and December. In all of those years are our 3 months of our highest readmissions. Now I want to know why. I don't know why, but we're going to soon find out. So far this year, we're at Q1 data only. We're at 4%. And I'm not worried about it because January's in there. And again, has always been a higher month of readmissions for us as a system. Not sure why. So, navigators, we currently have a stroke navigator in all of our certified hospitals. I should really say in all of our hospitals because I'm proud to say all of our hospitals in our system are certified by the Joint Commission. Our navigators are assigned to the certified centers, depending, they may have one or two hospitals that they cover, depending on the census. As I mentioned earlier, we follow our patients for 1 year post-discharge. Again, if they're discharged to one of our IPRs, if you remember, I said we have 4 IPRs that are connected to one of our hospitals. Our navigator follows them during that IPR stay. Our SNFs, we reach out, we touch base, we follow them after they leave the SNF. When the program was originated, we were funded. Remember, I said, remember this, it's important. We were funded via the Highmark Health. We reviewed our episodes of care for possible cost savings. We showed that improvement of care and satisfaction. We were able to improve patient satisfaction. We were able to decrease that cost in episode of care. Then we weren't able to demonstrate a decrease in episode for the SNFs and LTACs, though. We have no control over them. So we couldn't prove that point. The important thing to remember, though, when building your program is utilizing the return on investment. The return on investment is not always looked at as dollars and cents. Hence the importance of your data collection, and not just data, but the pertinent data that not only increases your patient outcomes, but also demonstrates success within your program and your organization. Each year, again, the care path models here are reviewed for performance utilizing a small subset of your patient of the patients within those care paths. And 1 year, about 2 years ago, still kind of gets me fired up. I was told that our program was not demonstrating any return on investment and that we were one of the lowest performing care models in the system. I knew better. I know what we do, and I know how good we are. And I'm a very competitive person, and I always want to be pretty much towards the top and the best. Um, so I reached out to Leslie, who is my guru, navigator with all the data info, and we went to work in less than 24 hours. And we looked at our data. We came up with touch points. We were able to show and demonstrate a return on investment in our care. So your data is going to be your very best friend. It's very time consuming. It makes some people grumpy. That's why I said you need somebody who likes data, who can perform in data, because it really is most important to your patient's outcome. We did not demonstrate a return, I'm sorry, we did demonstrate a return when we reviewed the episode, but we were able to, in this process, show that decrease in readmissions, a decrease in length of stay, an increase in our stroke patient satisfaction. We went from least performing care path and navigator program to the #1 care path at AHN and navigator program. So the return on investment is more than cost of an episode. That's all that administration was looking at, is the cost of episode. It's more. That's why your data is so important, that you have to prove that. In this data, you are able to obtain the buy-in of your administration when it shows um, an improvement. Your administration will then support you when you turn when you in turn are supporting the institution as well as increasing your outcomes and your patient satisfaction. Again, the key, supporting the institution, supporting patient outcomes and patient satisfaction. So to quickly conclude, I think you all would agree with me, stroke nurse navigators are essential. No matter how small or large your program is, they really do make a difference. We attempt to keep our navigator caseloads similar on size. That's why we have some covering fewer covering more hospitals. We have more than just one at Allegheny General, the larger hospital. So do we have a number that's the right number? No. But we try to keep it equal in size. Um, as you can see, the role of the stroke nurse navigator has many functions. They're continually evolving and are individualized with each patient. We were lucky to be part of that integrated delivery network that supported the start of the program, right? However, it was the work of the team and the data collection, the analyzation of the data that's maintained the program, which, like I said earlier, sits within our Neuroscience Institute. It's supported by the Institute. So, to conclude, a return on investment does not mean just dollars and cents. At the end of the day, track your data, show your worth, the outcomes of the work you do, your decreased length of stay, your decreased readmissions, your increased clinic follow up, and most importantly, better outcomes and increased patient satisfaction. These are some of the references that I used. And this is my contact information at that point now. Thank you all so very much. I hope you learned something, that it was interesting. And I
Pat,
love the picture of the city.
that is beautiful. Patty, what great information about, I'm on fire about getting stroke navigators here. I wanted to just, I know we've got a couple of minutes left, so I just wanted to include a couple of questions that came through. One is, how are you alerted when a patient is discharged from the STR, which I assume stroke rehab, they mean there?
So if they're at one of our rehabs, we are aware through our electronic documentation, and our navigators follow them within one of ours. If they are not, we use a system called CarePort, and you can follow a patient's episode of care within the CarePort. And the navigators essentially look at the CarePort every day.
And how does the navigator role differ from the stroke coordinator role? Do you have separate coordinators? If so, what is the ratio of coordinator to navigator?
So each one of our hospitals has a stroke manager slash coordinator. We're called stroke manager coordinator, and each hospital is assigned a stroke navigator. So again, depending on the size of the hospital, the amount of stroke patients they have, I have navigators. Oh my goodness, stroke navigators that cover 2 to 3 hospitals. They're very small hospitals. Here at Allegheny General, our comprehensive centers, we have 2 stroke navigators and a resource care associate. And she's a stroke navigator, but she's an LPN, so she has a different title, but she does the same role. So essentially 3 navigators at our large institution. Each navigator has anywhere from 350 to 420, 25 patients on their care list.
Wow. Okay. That was one of my questions, how many you were
We
responsible
don't know
for.
if that's right. We actually are in a process of trying to figure out if that's right with some of our high mark analytics people. That's one of our future goals, is to be able to say this is how many that each navigator needs.
Okay.
Haven't been able to do that yet, but
Well, we are at the top of the hour here. So, again, just wanted to thank you and thank all of the attendees today. This was a wonderful presentation, and I hope that everyone has a wonderful remainder of their afternoon. Thank you.
Thank you. Anybody can reach out to me with any questions.
Thanks, Patty.
Hmm.
Okay, I ended recording there.
Okay.
All right, great job, Patty. Really good information.
Thank you.
Seriously, we don't have that in our organization, and I would love to have it. We've looked at, even considered some of these, companies that do kind of pseudo navigation outside.
Yeah. I don't think it, and I didn't get into it, but we haven't, and